I had a meeting earlier today, and I had occasion to, we went around the table and did some introductions, and I had occasion to say that I was Al Mully, and I'd been at Dartmouth for 4 years, right after the passage of Medicare, and then at Harvard for 40, and now I'm back, and I feel like I've got the best job in healthcare because of the people that I came to work with, and that includes all of you, so it's good to be here with you. My job tonight is really to introduce our speakers, but I can't do that without thanking Dale. Those of you who were here at the noon hour heard me say a couple of times that I've only been here since November 15th. I hope that didn't sound offensive when I was trying to answer questions. But on November 15th, I met with Dale and learned that our guests had already been invited, and this evening's seminar had already been arranged. So it wouldn't be appropriate for me not to start without a big thank you to her for making this possible and taking the initiative. This is the first of what will be more than an occasional series of seminars where we will be doing our best to bring to Hanover some of the very best thinkers across disciplines, very best doers across contexts, and the very best communicators across constituencies and media, all trying to understand how to improve the quality of healthcare delivery and to do it in a way that reflects a sense of stewardship as well as a sense of real care and concern about the individual patients and the populations of patients for which we have some responsibility. We're going to begin with two presentations and then have ample time for discussion. Our first speaker is Jody Hoffer Gittell, who is currently at Brandeis at the Heller School, where she teaches operations management and HR. She has done some very noteworthy work that's drawn a lot of attention, helping us understand the Southwest Airlines way of working to provide a coordinating function to service delivery. And then she took what she learned in studying Southwest to healthcare and wrote High Performance Healthcare. She's, in the process, developed a theory of relational coordination, proposing that highly independent work is most effectively coordinated through relationships of shared goals, shared knowledge, and mutual respect among those who need to work together in order to provide the service. After we hear from Jody, Michele Molden will be giving a brief talk about her work at the Piedmont Hospital System. Michele, just over the last several weeks, has taken on the position of Chief Transformation Officer for the Piedmont system. Prior to that time, she has been Chief Executive Officer of the Piedmont Cardiology Institute, the Piedmont Heart Institute. And she assumed that role as Chief Executive Officer after being the person who managed the coming together of three quite independent, large cardiology practices that came together to, if you will, in Porter language, form integrated practice unit around some of the service delivery in cardiology. As a result, she spent a good deal of time learning about what Geisinger does, what Cleveland Clinic does in the same area, so that too should provide interesting food for thought and discussion. With that, let me turn it over to Jody.
All right. Thank you so much. I'm really thrilled to be here at Dartmouth and had a very stimulating day with conversations with colleagues at Tuck and the Dartmouth Institute and Dartmouth Hitchcock. So it's been like drinking from a water fountain today to realize how many people are thinking about these important issues around healthcare delivery. It's very refreshing. So I'm going to talk briefly today about my research in the airline industry and then how I came to do a similar kind of exploration of patient care delivery, and then talk briefly about my my new work in around the change process. So in this time of tremendous transformation of the healthcare industry, I'm now looking at, from kind of understanding in a more static way what drives performance, to how do we actually get from here to there. And then Michele will tell us how it really happens. So, all right, so with that, I'll start with where my work actually began, and that was at Logan Airport as a doctoral student at MIT, along with Rob Shumsky, who was also studying airlines from a different perspective. Started to observe the flight departure process. I was interested in how employees add value at the front line to organizational performance at a strategic level, and this is really what I observed. People from multiple functions trying to accomplish goals of simultaneously high quality and turning the plane quickly with as few staff as necessary, getting the plane off on time, as well as with the baggage that people were carrying, and getting the customers there with happy and satisfied. So I started to see some really interesting differences between two airlines that I was studying, American and Southwest. And so just a couple of illustrations of the dimensions of these differences. Here was a common comment at American, then later at Continental and United as well. Here you don't communicate. Sometimes you end up not knowing things. This is a gate agent talking. On the gates, I can't tell you the number of times you get the wrong information from ops. The hardest thing at the gate when flights are delayed is to get information. And then having a similar conversation with people at Southwest, and this was the Chicago station that I visited. This was the kind of comment that I would frequently hear. Here there's constant communication between customer service and the ramp. When planes have to be switched, bags must be moved. Customer service will advise the ramp directly or through ops. Ops keeps everyone informed. It happens smoothly. Okay, well that's a difference. That's interesting characterization. So often in any complex, time-constrained, interdependent work process with a lot of uncertainty coming from the environment, you do have things that go wrong. So one of the things I started to explore is what's the communication pattern around problem solving? And this was a very typical comment that I then heard in many versions in many organizations, even beyond airlines. If you ask anyone here what's the last thing you think of when there's a problem, I bet your bottom dollar it's the customer. And these are guys who work hard every day, but they're thinking, how do I stay out of trouble? So the reaction to a problem was more, how do I make sure this doesn't get pinned on me, as opposed to what happened and how do we fix it? And it's called finger pointing, and it turns out that it's very common in many industries, even academia, heaven forbid. And at Southwest, it was a very different response that people characterized. We figure out that this is a pilot speaking. We figure out the cause of the delay. We don't necessarily chastise them. Sometimes that comes into play. It's a matter of working together, figuring out what we can learn, not finger pointing. And so I started to think, well, there's something going on here that's more than just the communication, but maybe the underlying relationships, and started to pay attention to comments about these deeper relationships involving goals. This was a common comment at American and some of the other airlines. 90% of the ramp employees don't care what happens, even if the walls fall down, as long as they get their check. This is someone speaking from customer service, and you would often get comments, for example, oh, the pilots don't really care. They just want to fly their flights and then go out and sail their yachts. And this sense that really people weren't all aligned with the same goal for the organization. And more typically, this is what I was hearing at Southwest. I've never seen so many people work so hard to do one thing. You see people checking their watches to get the on-time departure. They work hard. Then it's over and you're back on time. And regardless of which function I would ask, people would say, we're here to get you there safely, on time, with your bags, and happy. It was very common, regardless of your particular task, there was more a sense of, ultimately, this is what we're trying to do, and it doesn't matter if I'm a sky cap or a pilot. And something that it really struck me was the difference in how much people knew beyond their own task and beyond their own area of specialization. Turns out that's pretty relevant in healthcare, where we have very deep areas of functional expertise. Employees at American often would describe things in terms of, well, when the bell rings, I go out and I offload the bags and I unload the new set of bags, and I come back and wait for the next bell. Really very specific around their task. And asking people the same question at Southwest, you would get a very detailed explanation of why I'm doing this and how this information matters for the pilot and it matters for the downline station, and if I load it this way, it makes it easier on the other end, and very much an awareness of the interrelatedness of what they did and its impact on the other functions, which tended to give them a sense that their work was quite important, actually. And then this final issue, which feeds right into that, which is of respect. A lot of status kind of hierarchies in the airlines, as we see in many industries. There are employees working here who think they're better than other employees. Gate and ticket agents think they're better than the ramp. The ramp think they're better than cabin cleaners, think it's a sissy woman's job. Then the cabin cleaners look down on the building cleaners. The mechanics think the ramp are a bunch of luggage handlers. And this was not unusual. You know, one of the other stations, the customer service, people would call them the ramp rats, and the ramp called them the customer service trash. And you know, a lot of kind of jockeying for who is below me in this status hierarchy. And this is probably the most powerful difference that just came through loud and clear consistently, and that was this notion at Southwest that every job here is important, or we wouldn't have it. No one takes the job of another person for granted. The sky cap is just as critical as the pilot. You can always count on the next guy standing there. No one department is any more important than another. So I started to develop this notion that coordination was highly influenced by the nature of the relationships, because relationships were shaping the quality of communication through which work was coordinated. And that was happening in different patterns, sometimes in this very positive cycle, shared goals, shared knowledge, mutual respect, driving frequent, timely, problem-solving communication. But often it was more locked into a negative cycle, which was around strictly functional goals without as much of a perception of how ultimately we are striving for the same goal. Very specialized knowledge without the context of how my specialized knowledge interfaces with yours, and a sense of lack of respect from others, which tended to drive less frequent communication, often delayed. People weren't as aware as of who needed to know what and when there was a time crunch, and finger pointing more than problem solving when things went wrong. So at this point, this is a hypothesis that I wanted to test as a doctoral student. And I just gave it a name, relational coordination, and ended up defining it as communicating and relating for the purpose of task integration. So basically the relational and communication networks through which coordination occurs. And wanted to look at, well, how does this affect performance? It seemed like it could potentially influence both efficiency, how quickly and efficiently you could get something done, and also the reliability of your outcomes. So wanted to test that, did this 9-site study, measured this, developed a relational coordination network survey, which I'll show you in a bit, and looked at these quality and efficiency outcomes, adjusting like we risk adjust for patient differences, and doing that in the flight departure context. And without going into so many details, looked at the impact on this turnaround time at the gate. That's the scheduled turnaround time, that's time that the plane is not earning revenue, and it's time that the gate is being tied up. So it's valuable real estate and valuable resources that are being used up the longer you schedule a flight to be at the gate. The staff time, this is basically an employee productivity measure, customer complaints, lost bags, late arrivals, and relational coordination moved each one of those in a significant way. And so what looking at a scatter plot and putting quality and efficiency metrics together, you see this kind of picture, where the two sites at Southwest are quite different. They had picked what they thought was their highest and their lowest performing site at the time, interested in what we could learn from this study. And so you see that relational coordination adjusting for other differences in the product mix, like degrees, percent of connections, and so on, does drive both of these measures in an interesting way. And I wanted to understand, because people would say, well, that's a Southwest thing. And how do you know it's not just this, funky Texas company that just has some magic formula that can't really be transferred anywhere else? So at about this time, I went into the hospital as a patient, as a first time as a patient to have a baby. And of course, everything I saw looked pretty similar. Like, wow, this is exactly like flight departures. What is going on? I mean, this is actually more complex than what I was going through. But my thought at the time was I would try this and see this is like a very similar challenge, more challenging in fact, because you don't have a batch process where you put 130 passengers on one plane. It's really the one at a time kind of production process that's more, and a lot less, a lot more emergent information regarding an individual patient. But the coordination challenges are obvious, and people had been, were starting at the time and in the subsequent years to talk about this. The Institute of Medicine was highlighting the fact that the current system is really poor at this, in fact. And each discipline and type of organization tends to defend its authority at the expense of the total system's function. And it seemed that some of the coordination and fragmentation was due to the kind of territoriality and status differences that were visible in the airline industry. In fact, I was so impressed with the nurses while I was a patient. They would hand off to each other saying, okay, I know you've just heard this, but I wanted to reiterate it and then tell you something else. And they had these great handoffs with each other. And I said, what have you been doing? I'm really impressed. They said, we've been doing TQM and it's really working well. And I said, well, when's my doctor coming? Oh, we don't know. They don't tell us anything. So again, it was this kind of thing where you have fairly good coordination, in most organizations within those bubbles, and you go across where you tend to get the drop-off unless there are very deliberate efforts to remedy that. And some of the physicians I interviewed, I think this was Clem Sledge, who was just leaving as the chair of chief of orthopedics at the Brigham at the time. The communication line just wasn't there. We thought it was, but it wasn't. We talk to nurses every day, but we aren't really communicating. And nurses were having similar comments. This was a nurse leader at the MGH. Miscommunication between the physician and the nurse is common because so many things are happening so quickly with the shortened length of stay, I mean, clearly. But because patients are in and out so quickly, it's even more important that we communicate well. So people were noticing this dilemma, and it was clearly something worthy of exploration. So I did the same study in the hospital setting, looked at joint replacement patients, hips and knees, not because it's the most complex thing that the healthcare system does by any means, but because there was a pretty well established outcomes model for that kind of patient. I was working with people at the Brigham, like Jeff Katz, who had developed this with the, the risk adjustment and so on, so we really could see what difference an organizational factor like relational coordination might make. And so we did a very similar study looking at patient satisfaction, length of stay, and pain and mobility outcomes using the WOMAC, which was, and I think still is, considered the gold standard for patient-perceived clinical outcomes of joint replacement surgery. And just summarizing that in this format, looking at quality and efficiency performance risk-adjusted against relational coordination, there was significant variation on both sides, and again, similar kind of pattern of outcomes. And when in some ways it seems really obvious, but when I talked sometimes to I'm thinking of an orthopedic surgeon who was at a board level meeting in the north east of England, an NHS Strategic Health Authority, and he came up to me after a presentation and said, I believe the results. I mean, I read the paper in medical care. I understand what you're finding, but it's still very hard for myself and my colleagues to realize that it's not just what we're doing in the operating room that is driving some of these important clinical outcomes. So even though on one hand it's obvious, on the other hand, it goes beyond the usual medical model of what's driving clinical outcomes. And I think it's important from a service delivery system design standpoint. So we've now extended these to other settings. I'd be happy to talk about some of these other findings. Outpatient clearly is becoming more and more important piece of the healthcare system, so this really needs, in fact, it's more of a challenge there, but more critical again to achieve. I just want to put this in the context of other ways of achieving coordination, because we've got, coming from an ops perspective, and there are other ways to achieve coordination around reengineering, lean, total quality management. A lot of them really are about integrating work processes more effectively to achieve quality and efficiency improvements. So how do I put this in that context? This is a health leader at Tenet who said, kind of gave me interesting thought. We've been doing process improvement for several years. We think we're on the right track, but we've tried a number of tools and they don't address the relationship issues that are holding us back. So one way to look at this really is to see relational coordination, these coordination networks, as providing the relational underpinnings for doing effective process improvement or lean strategies. That the two aren't, it's not either or, but the two could be quite effective together in terms of using some of the tools of lean even to elucidate what are the task interdependencies here, who is involved, even if it's not obvious, and doing the 5 whys that help you track back what could be leading to the outcomes and develop the hypotheses which you can then test and act upon the results. So this notion that these relationships help people to connect in a meaningful way across functional, organizational boundaries and see their connections in a way that's not always obvious given the way organizations are set up in more bureaucratic, siloed ways. So how does it, there are some interesting impacts that have been measured primarily with workers, but with nurses, but also across professions. This finding that relational coordination is associated with higher job satisfaction for multiple disciplines. And then when we drill down and look at nurses in a more detailed study, it increases their sense of professional efficacy. Reported burnout is lower with higher levels of relational coordination and less emotional exhaustion. So one sense, there's pretty well-established findings in social psychology that social connections help resilience and help people deal with stress more effectively. So this notion that in stressful jobs, which, healthcare is a stressful place to work, that these relationships are helpful because they allow you to get your job done effectively, but also provide that support and sense that you're not in it alone. So one way of depicting this is that it helps to kind of shift out this production possibilities frontier where you're shifting off between quality and efficiency and enable to improve multiple outcomes simultaneously, like you would with any fundamental process improvement. So here's the notion of how would you actually go about the change process. So many people, as I've talked over the years, starting with the Southwest and then the healthcare study, well, how do we actually get from here to there? And you'll see there's a whole set of organizational practices that help to sustain relational coordination over time. But how do you actually get it jump-started? And here's a thought that people are starting to use in different interventions, that you actually start with process improvement, which is being done throughout the healthcare system. Choose a focal work process and who are the work groups involved, including often the patient. Look at your key performance outcomes that you're trying to achieve, create this network map and use relational coordination to actually assess the strength of ties. And I did this, it's not just healthcare, I did this with British Petroleum a couple of weeks ago, and they were able to think about it in this way. What's the work process? Who are the critical work groups involved? And then these 7 questions. We've actually added one now, accurate communication for the healthcare arena, because it becomes apparent that the accuracy of communication is really critical. And the questions all look like this. You're answering them with respect to each other work group involved in the work process, including your own, and able then to map and see, okay, where are the weak ties, where are the strong ties? You see typically you have fairly strong ties within these, within function, and then weaker ties between. But in this case, this was a neonatology practice. The physicians had fairly weak ties even with each other. And this was a group that was having trouble and had called a consultant in to help. And then we had some significant improvements, particularly among the physicians, and I'd be happy to talk more about this intervention later. But there's really, I like to talk about a 2-part intervention, because it's one thing to find ways to do coaching and mentoring and process improvement to help create more positive relational dynamics that can help us achieve performance outcomes. But then, we do a lot of project improvement, project by project process improvement. How do you sustain that over time? Because I often go into healthcare organizations where I say, well, we're working on this, and then we move on and work on that, and we lose what we gained there. And this notion that you need some organizational infrastructure to really help support these patterns over time. And so the second piece of my research was, both at Southwest and the airline industry and healthcare, what are the organizational practices that predict higher levels of relational coordination. And this doesn't tell us necessarily how we change, but how we sustain over time. These are places that not only select nurses and physical therapists and social workers for their ability to work as part of a team with other disciplines, they select their physicians that way as well. They select their pilots that way as well, their mechanics. Functions that typically are chosen explicitly for technical expertise, but not also for the relational competence. So this notion of taking something we do every day, we select, we measure, we reward, we resolve conflicts, and so on, but redesigning those practices in ways that don't, rather than reinforcing the silos, actually reinforce the horizontal ties across the work process. And I call that form sometimes a relational bureaucracy, because you're using formal practices to really reinforce the relationships that follow the lines of the work. And it's not rocket science, but it is a different way to think about structuring formal practices. So instead of having conflict resolution that's primarily vertical within a function, to build proactive conflict resolution across disciplines. And it's harder to do than it sounds, because there are a lot of sensitivities around that, but to really take it on is a powerful way to really sustain these relational dynamics. And so I just wanted to conclude really with this notion of, it's a different kind of set of work practices. It has the potential to increase both worker engagement and patient engagement. And with all the discussion, and I think a lot of healthcare, the promise of new forms of healthcare delivery are wrapped up in the notion of not only coordination across providers, but partnering with the patient and making them really a co-producer of the outcomes. That's so much of the wellness model, and I think where the promise lays in terms of reverse innovation and so on. So the idea, and this needs to be explored further, but the intuition here is that by connecting people around the patient, you start to create the opportunity for more engagement, because people see it's not just their job they're doing, but they really are part of serving the patient, and it gives a broader view. So someone, for example, in housekeeping who understands that how clean that room is part of, critical part of achieving the goal of minimizing hospital-acquired infections, gives a lot more purpose to that job than you would otherwise have. And by engaging with each other around the patient, you also have this potential for partnering with the patient as another member of that team to help achieve the outcome by developing with them as well shared goals, shared knowledge, mutual respect. So some of those same relational dynamics that I think drive relational coordination could also be there in this co-production process. And I think we need to explore that further. So just a kind of summary, this step one could be to identify a work process, map it out, and do the kind of, not only the mapping of the work process, but the relational dynamics around it, and we have tools for both, and involve the patient in that figure, because often the best test of whether a work process is integrated is to follow the patient and see what do they see duplicated over and over again, where are the, so really involving the patient is one of the best ways to understand how the work process really works, measure the critical performance outcomes and so on. And then using that information, conduct the process improvement to improve the work process, but at the same time, engage in the coaching and intervention, which is still being experimented with in many places, coaching of the participants to build shared goals, shared knowledge, and mutual respect among them. And part of that mapping process is to make more visible how we all connect toward achieving a set of performance outcomes. And so I think it's quite synergistic. Of course, measure performance again, measure the relational ties, and really review the results and so on. And I think this kind of, this is the kind of, what did Jim Kim call it? Randomized evaluation, where you can have experiments across your system and in other systems and really evaluate before and after and comparison across to see what's working, what are the interventions that are making a difference. And then step back and really assess the work practices that if they're left unchanged, they probably will push people right back into the old patterns of interaction, because how we're selected, trained, rewarded, measured, and so on will push us back into the same silos unless they are transformed to really support these new patterns. So this is a job that can take some time, involving HR, operations, the frontline providers themselves, the patients, to think about what is a longer-term plan for transforming this basic organizational infrastructure that we have here in healthcare systems. And that's it. So I'd like to thank you.
Let me just encourage you all. We're gonna go from one talk into the next. I know that presentation from Jody stimulated a lot of questions in my mind. Let me suggest that you jog down some questions so that you don't lose track of them after hearing what I know is going to be just as stimulating a presentation.
And in the meantime, Michelle's going to answer all those questions before we even ask them.
Hardly. We just need a slide set, and I think we're good. Well, let me start. What I want to do is just tell you a story. And it will embody, I believe, many of the principles that Jody talked about. And I'm going to give you a little bit of the good, the bad, and the ugly of the story. Because, of course, in these complex systems that we work within, it's not all perfect. So let me start with the context of the system. I work in Atlanta, Georgia for Piedmont Healthcare. It is a 4-hospital system in a very different market. So when you think about the market you're in, think about a market of 6 million people, probably one of the most hyper-competitive and fragmented markets in the country. 28 county area with 43 providers in those counties. So when you think about an identity or a healthcare system in a different market than one you might be experienced with, you'll help understand what happened. This gives you a little background for the healthcare system, big primary care network, and then the opportunity to form a very large cardiology group. Actually now cardiovascular group. You know all of this. There's so much misalignment of incentives in our organization that it creates incredible barriers to relationship coordination and everything that Jody's been talking about. This is one of my favorite slides, and this is from a consultant friend of mine, Nate Kaufman, and it says that, well, you can read what it says, and you know this if you've been either from Mars or Uranus. And so what a physician hears when he hears an administrator speak is blah, 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 meeting compliance, blah, 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 no. Now that's if you get a no. And most of the physicians I talk to talk about the slow no, which is the answer they never get. On the other side of the equation, what the administrator hears when the physicians speak is blah, 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 money, blah, 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 or I will leave. So when you start with a substrate like that, your challenge is, how do you even begin a relationship process that bridges that divide? And so I'll explain this as we go, but the story begins when at Piedmont there were 2 large cardiology groups. At a competitor hospital there was the dominant group in the community, the largest and most aggressive cardiology group. Now this really speaks to the power of physician leadership, which I will reinforce many times in this discussion. The 3 leaders of those cardiology groups came together and said, what might the world look like if we stopped competing, started to collaborate, and picked a healthcare system to be our partner? For a lot of reasons I won't go into, Piedmont was ready for that history of physician alignment and integration. Piedmont was started by 2 physicians. The board is chaired, coincidentally at the time, by an interventional cardiologist. And so a lot of history of physician alignment, much of which I was involved in because I will tell you I've built every rickety bridge that there is to build between hospitals and physicians, have done a number of joint ventures. So we had the opportunity to bring these 3 big groups together, and we did. And in a period of 9 months, we moved the group from the competitor hospital to Piedmont and brought 3 competitors together comprising 62 cardiologists. When I look back on it, I realized that much of what happened to make that work was exactly what Jody's talking about. We first thought very intentionally about the culture we were trying to form. And we went to each group and said to them very formally in a dinner with each individual group, what are the things that you want to bring to this culture and what do you want to discard because your old culture dies tonight and our new culture is born tomorrow. And that actually became an incredible engine for us that has since led to not just the cultural underpinnings of this organization, but our physicians taking it many steps further, and I'll show you that into how we're actually organized, but they've now taken it to a physician credo. So that culture was translated into values. Those values have become the things that our physicians measure each other on and have to sign a document saying that they will live up to. And we've actually had instances where people who are not physicians have gone up to our physicians and have said, that's a credo violation, and I'm calling you on it. And I knew we had succeeded the day that nothing was thrown and no four-letter words were used. And the physician in question said, thank you very much. I appreciate that. So we formed this big group and then realized we had no alignment with our hospital system. We were a bunch of doctors all together, and a woman and a CFO who was not a physician. We had a commitment to be physician governed and physician managed, but we had no relationship with our hospital system. So we set about developing that relationship and created a service line model. So today we run all of the cardiovascular services across our system. All the cath labs, all the ORs, all of the interventional areas and the imaging centers report through the Heart Institute. That was a huge leap of faith for our system to give over that much control because by now the inmates really had taken over the asylum. And we were in the process of organizing a care delivery system that would involve frontline workers as well as our physicians, and we did that. This just tells you that across our 4 hospital system, we have all of the components of a service line structure. The very interesting thing is that we organized ourselves around centers of excellence. So trying to become more patient-centric, we said to ourselves, if we're really interested in patient care, we will organize ourselves around disease process, not around functional area. So you can see the centers of excellence. We've actually added another one that's sleep, but we have a chief of each one of those centers. Every physician who's involved, for instance, in treating vascular disease, is in the Vascular Center of Excellence. So vascular surgeons, I forgot to mention that over the last 2 years, we've also added vascular surgery, thoracic surgery, and cardiovascular surgery. So today we have just about 100 physicians in the group that really span the gamut of cardiovascular care. So every physician who has anything to do with that patient sits in that Center of Excellence. And they develop the quality metrics, the research parameters and studies that center is going to go after, the strategic plans, and then what they need to fuel those strategic plans. The chiefs of the centers of excellence then work with senior management to prioritize among all of those and come forward with one coordinated plan. You can imagine there's a lot of discussion about how those priorities get fueled. But this has also allowed us to take the leadership model and distribute it throughout the practice. So where we started with 3 or 4 physicians who really led the group with me, today on our main campus, we have about 30 physicians that are involved in some way in a distributed leadership model. What that's done, and this was really a precursor to the credo, is it's created physician owners. So our physicians, they're not equity owners. There's no equity here. All of the profits and losses accrue right to the healthcare system. But through this model, we've been able to create the sense that our physicians really own their destiny, that it's their opportunity to create something that is highly differentiable in the market and really creates a destination site for heart care in the Southeast, because there isn't one today. I know there's some people that would argue with me about that. So, but that has really enabled us to do many of the things around the relationships that Jody talked about, because the first thing that we had to do was build trust and respect. And part of that was giving over power and giving over control and believing that our physicians were better understood what needed to happen for their patients in our laboratories than we did, than an administrator could know sitting behind a desk. And for us, it's been very, very effective. This is just kind of, it's, I put this in here because it's different than Jody's STAR model, but it really depicts the same thing, where all of our outcomes are distributed across our centers of excellence from both the strategic to the tactical. It's just, in my view, a way of demonstrating a very similar spiderweb model, if you will, that connects all of our thoughts and ideas, both across physicians, nurses. We have about 75 nurse practitioners and PAs that practice with us, and they're all involved in the centers of excellence and their work as well. The thing I'm going to mention is the thing that we did very poorly, and that is we managed to create a great culture and I think a very effective model in the Heart Institute that has reduced cost for our system, increased quality, increased performance metrics. And so the question about should the inmates be taking over the asylum, I think, has been answered. The problem is, and I really missed this one, I was so attentive in forming the culture of the Heart Institute that I forgot that an innovative startup inside a $1.3 billion organization might be a little bit challenging, and that the core organization might push back just a little bit. I won't show you the scars, they're deep and wide, but I will say that I could have done a far better job of thinking through that at the outset and putting the same model in place that we'd done within the Heart Institute to connect it to the system. This is a late attempt to do that, where we put every one of the CEOs across our healthcare system on the Piedmont Heart Institute board. But that's only a year old when we realized that this terribly unruly toddler was on everybody's last nerve. We thought, how can we really bring the leadership of the system into what we're doing and make it not threatening for them any longer? So in addition to all the physicians on the board, we have each one of our CEOs of our subsidiary organizations in the healthcare system, all of the hospitals that sit on the Heart Institute board. Interestingly, of the 11 boards that the healthcare system has, this is the only board where all of the CEOs sit together. So, a brief case study, and what I would echo in spades, everything that Jody talked about. The key to doing this was the independent and personal relationship that we each had with each member of the organization as it was forming. The creation of a cultural context that really then translated itself into very specific outcome measures and very specific parameters that have really changed our organization at the Heart Institute level, and I think will change the healthcare system. My new role is to now create this in a variety of other contexts. So, with that, I think it's time for questions.
I'm going to stand, so I think the two stools will be fine. Fascinating presentations independently, and the intersection make them even more fascinating. So first question, and let's I'm I'm looking at Gene because I'm wondering about what he's thinking with regard to clinical microsystems, and how what he's been hearing is similar with a different vocabulary or different.
Yes, thanks. I was very interested in the Southwest Airlines and then the transition to healthcare, and your path forward was, I thought, very, very similar to the kind of work that different frontline clinical teams have done to improve their own performance, or to bring together assorted clinical microsystems that serve a particular patient population and use the same process. So I was very impressed with what you were doing. I was also reminded of the work of Brenda Zimmerman, who was a physics school professor at Schulich, and brought into this work the idea of, she calls it the generative star diagram, and looks at the relationships amongst people, and it is something that we've incorporated into the working with frontline interdisciplinary clinical teams and engaging the patients in that co-design, co-improvement process as well. So I thought it was great.
Thank you. And
I was wondering if you knew of Brenda Zimmerman's work.
I don't, and that's why I'm taking notes here. Where does she teach?
Schulich, School of Business in Toronto.
Okay. Yeah, I keep hearing.
Complexity science maven.
Okay, yeah, that's a really interesting, it's a group, Complexity Science, I think, is very interested in the complex health systems and the coordination challenges around them. And it's funny, I just got back from a 10-day speaking tour in Denmark, and almost every day someone would say, oh, do you know so-and-so in Toronto, and who's doing work on interprofessional collaboration or various, I do think there's something really interesting going on where there's almost a co-creation of some of these similar ideas in different places, because the timing is so, the system is really calling for it. And it's not just within the US, but in areas of the world that have very different payment systems, which really reinforces this notion it's not just about how we pay people. There's something more fundamentally similar about healthcare delivery that is a challenge even when you have a single payer system. So that's very cool to hear.
One other comment. Your comment on coaching, I think, is extremely relevant and important. Mark explained that Margie Godfrey has started a microsystem academy, and one of the courses they offer is coaching the coach. And Edgar Schein's work on helpful people has been extremely informative on creating coaching capacity of healthcare professionals to coach frontline teams in both the relational as well as the performance, direct performance perspective. So the coaching role is extremely important.
I keep hearing that in very different places too, and Ed Schein's going to be thrilled to hear this, because I'm working with him and Amy Edmondson around what are these intervention models that are useful, and I think what he's bringing to the table is all this recent work on helping and the importance of developing the capacity to help for change to occur. So thank you so much.
Other questions?
Thank you both. This notion of relational coordination or relational warfare in Piedmont, I don't know, but the quantification of that is, I think, the interesting part, so that you can act upon it in some defined way. And so when the doctors at the Brigham on the joint service got the information that their coordination or relational coordination was less than the nurses, what's the, you said you could talk more about it. I'm wondering what the action item is, and then do they retest until they get to a certain level? Or, and I imagine at Piedmont, there's the same thing, it's just not as quantitative, but.
Well, it was really an interest. I do think that being able to measure it is helpful as we move into this era of evidence-based change processes. And if you can't measure it, it's such a soft quality anyway. If you can't measure it, it really lacks credibility. So that is an important characteristic. As far as the intervention, the intervention I described, ultimately, I think we all see it as only a partial success because it was so focused on the physicians and their dysfunctional behavior at the time. There was a lot of uncivility and so on, that the intervention around the physicians was effective, but because it was not more holistic, some of the other relationships either stayed the same or actually got worse. And I think that focus on physicians tended to reinforce this notion that the others were less important. And when you're doing something that involves a work process and trying to build a more holistic perspective on how this collaboration occurs, it can actually, it could be counterproductive to have a single discipline focus rather than this more collaborative. So although there was gain in that one area, I think it could have been more effective to have a more cross-functional approach.
So if in the Piedmont experiment you had quantified things, how would that have helped you or hindered you?
I agree. I think quantification, particularly working with physicians, is always more effective because the targets are there. But I will say this, that we had worked very hard on building certain patient satisfaction metrics for the staff and for the physicians. And I think to Jody's point, we'd placed such a focus on the physicians during the integration that the staff felt very, I think that we were asking them to do something we were not asking of the physicians. The physician credo in our system really changed that fundamentally because we said to our staff, it's your responsibility to hold our physicians accountable. And the credo is not for staff, it's just for the physicians. And our staff went, wow, so for the first time, you're actually allowing us to hold them accountable, and there's a whole process around credo violations. And so not a quantification, but a very public, and at our monthly meetings, we publish credo violations. Here's what's happened, and very openly, very transparently. So a different way to get to the same point, but I would agree we tend sometimes to focus too much on physicians.
But it's interesting because the intervention where it was successful with improving physician interactions, there was, the coaching was really around accountability for their relational behaviors and holding each other accountable for that. And if that were then broadened out, it could have, I thought that was a very powerful part of the change process that you described. And I'd like to.
Carol had a question.
I have observed over the years that there doesn't seem to be much training in teamwork for at least medical school. I imagine nursing may have a little bit more. Can you envision a course or a place in the course where introduction to what it means to be part of a team would be effective?
I think that's really the place where we need to go beyond the health delivery into the health education, and I love the fact that people are thinking about both of them simultaneously. One of the examples that I've heard that people feel has some promise is to take, for example, the residency and make one of the rotations around patient safety and process improvement. So in addition to the clinical rotations, there's one that helps people and physicians in this case, to think about the larger system of which they are a part and work collaboratively with the other disciplines to on process improvement. I think that has a lot of potential, and this notion that there's got to be some way, but as Dale points out, if you learn that and then you go into back into your other rotations and find that the role modeling is still for the old behaviors, it's got to somehow take what's done in that educational setting and then reinforce it as people go into the workplace. But I do think there's some real potential there.
One or two more, Barry?
I just have a question following up on that. In obstetrics, which I consider the ultimate team sport, in your work, did you find any generation? You're talking about physicians as one group. I would think we find both in risk management and in safety, there's a huge generational differences. Did you find much difference in converting or barriers based on the, let's say, the age or the gender of the physicians you're working with that we have to deal with differently than one group than another, as far as acceptance of the new culture, the new guidelines, change?
I found that anecdotally, and a lot of good hypotheses that deserve testing, like the ones you might be putting forward, but I haven't looked at it systematically. I was surprised to learn that as far as the partnering with the patient, some of the younger physicians are somewhat threatened by that. When patients bring to them information that they've gotten off the internet, I thought they'd be more readily embrace that, but it can feel threatening even to a young physician who is maybe very accustomed to finding information in that way. So I do, one source of anecdotal evidence is I teach the Tufts Brandeis MD MBA students ops management. And I would say just 5 years ago, we could really get a good debate going about whether clinical pathways were a useful thing and what was the upside versus downside potential of clinical pathways. Now, with the current cohorts, I can't even get them to debate it. They're like, of course. We want to be tracking, we want to be finding best practices and continually collecting data and improving best practice through pathways. So I do think that there's a generational switch that is much more amenable to taking an operational approach and a data-driven approach. Some of the things will die hard, though, and I think that part of that is the notion of what it means to be a professional and how I interact with the patient. But that's another.
One last question.
I just want to make a comment about this. The Association of American Medical Colleges is trying to focus on precisely what you're talking about. They are in the wake of the report Educating Physicians from the Carnegie Institute. They've been advocating this integration across the curriculum for quality integration, medical students, residents, and the faculty. And in June, they're holding a conference where these are precisely the topics that are going to be discussed, and people are going to be demonstrating the different ways in which they're doing that within academic medical centers or medical schools or integrated institutions or whatever. So places like UCF and Hopkins and others are going to be presenting what they're doing, and a lot of the work is new, it's brand new, it's experimental. People are trying to do precisely what you're advocating, but it's exciting to see that a lot of organizations get it, and starting to get it.
Very exciting, and I think Dartmouth could be out in front as well because it's so consistent with the goal of transforming the delivery of healthcare. We really need to transform the inputs, some of those most critical inputs into the delivery system, which are our providers.
I think the question that, most interesting question that I take away from your two presentations is about where does the responsibility lie? I mean, given the stunning correlation between quality, efficiency, and measures of relational coordination, and given that we're really talking about power hierarchies or status hierarchies that are related to levels of training and perceived levels of competence in organizations, your description of the comments about the status talk in the AMR Airlines setting, for instance, it's hard not to think that the pilots would have perhaps the most influence in doing something about that, as opposed to the baggage handlers or as opposed to the cabin cleaners, who might have the very least influence. That's the question that I take away from this in thinking about where does responsibility lie for flattening dysfunctional knowledge power hierarchies. And with that, let me thank you, Jody. Thank you, Michele. And also, again, thank Dale. And we also have Dale to thank for the fact that there are there's some light refreshments, including some beverages outside for those who would like to continue the conversation. Thank you very much.
Thank you.